Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clirnet, serving as the allocated session assistant to ensure a seamless experience. Clirnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clirnet serves as a digital partner for this event hosted by National Medicos Organization, and the focus of today's session is Physiology Clinical Cases Discussion, Day 2. So let's begin with today's session. Over to Sir.
Yes, thank you, Rimpa. Good evening, everyone. I am Ajay, representing National Medicos Organization and GSL Medical College. Welcome to our 4-day series. Today is J2. Our speaker is for this evening is Dr. Pernenki Srinivasa Rao, sir, Professor, Department of Physiology, GSL Medical College, and President, Arogya Bharati, Andhra Pradesh. Sir will be speaking on Endocrinology Part 2. And we also honored to have with us Dr. Sagar, sir, Organizing Secretary, National Medicos Organization. A special thanks to our digital partner, Team Clirnet, Mrs. Ritu, our coordinator, and Mrs. Rimpa, our moderator. To begin the session on an auspicious note, I will start with this sloka. Thank you.
नमामि धन्वन्तरिमादिदेवम् सुरासुरैर्वन्दितपादपद्मम् लोके जरावृत्भयमृत्युनाशम् तातारमीशं विविधौषधीनाम्.
Thank you, everyone. Sir, can you start?
Okay. Thank you very much, Ajay, for organizing
Thank
this
you, sir.
meet.
Thank you,
So,
sir.
as I was telling yesterday, why we have taken this up is because of the questions which are going to be case oriented have increased. And also, we have something called, MCQs also, which are case oriented, and some questions where you have to have reasoning. So that's why in my talk yesterday also, I tried to reason out the questions and give you the answers. So this reasoning is very important for you to understand the subject. As you all know, most of the people forget about the physiological basis of the disease when they come to the final year. So it is very heartening to note that most of the people, though they are of the first year, I'm happy to say that many of you are from third year, fourth year also. So I hope this was useful for you yesterday. So today we'll be talking about the rest of the clinical cases. Yesterday we completed thyroid gland. A 37-year-old woman presents with a 6-month history of progressive weight gain, muscle weakness, and irregular menstrual cycles. She reports easy bruising, mood swings, and increased facial hair. Increased facial hair is called hirsutism. Okay? On examination, blood pressure was 165 by 100 millimeters mercury. So she is hypertensive. Truncal opacity with thin limbs. Reddish purple striae on the abdomen. Moon-shaped face and supraclavicular fat pads. Proximal muscle weakness. That means when she's climbing stairs, she's finding it difficult. Proximal muscle weakness. And in the laboratory test, fasting glucose was 145 milligrams per 100 ml. So it is increased. Serum cortisol is increased. Plasma ACTH is also elevated. Then a test which is called low dose dexamethasone suppression test. There was not much of a change. High dose dexamethasone suppression test, partial suppression of cortisol was there. MRI of the pituitary showed a lesion. Anyone can tell what this could be? You can type the answer. A 37-year-old woman presents with a 6-month history of progressive weight gain. So there is weight gain, muscle weakness, irregular menstrual cycles, easy bruising means she gets injured very easily, mood swings, increased facial hair. Anyone? Very good. So it is Cushing syndrome. So here I have put so many symptoms like weight gain, slow healing of cuts, that is called easy bruising, increased risk of infections, fatigue, glucose intolerance. So just because there is an increase in the blood glucose, don't write it as diabetes mellitus. This is a common mistake which students make. When they see that the patient is obese and you have an increased blood glucose, they write it as diabetes mellitus. So remember, there are so many diseases where the blood sugar is increased. Yesterday we had a disease where there was an increase in the blood sugar. What was that? Yes, hyperthyroidism. In hyperthyroidism also we had an increase in the blood glucose. Here also there is an increase in the blood glucose. We'll tell why. Then psychological, depression, anxiety, irritability, loss of emotional control, cognitive difficulties, decreased libido. So many changes are seen. But the most important is the purple striae, which are called the stretch marks. So if you have an obese patient with a buffalo hump, so you can see near the back, there is something called a buffalo hump. And the face is round, Chandramukhi, round moon faces. So remember that. If it is a Chandramukhi with a buffalo hump and thin legs, thin extremities, and stretch marks, then it is definitely a case of Cushing syndrome. Hirsutism is also seen. That means excessive hair, I told you. Then acne. Acne means pimples. That is also present. Then irregular or absent menstrual periods in females, erectile dysfunction in males, then bones, increased risk of fractures, vascular, new or worsened high blood pressure. Though I have written this as a Cushing syndrome and it is a disease, most commonly in clinical practice, we see this because of increased usage of steroids. The disease as such is a little not very common, but people who use this steroids for a long time come with the same signs and symptoms. So remember that it could be iatrogenic. That is called iatrogenic. That means it is the disease is made by the doctor. Yeah. So based on the data, what is the most likely cause of her Cushing syndrome? So here there was an ACTH suppression test, isn't it? So what is the cause of her Cushing syndrome? Whether it was the adrenal cortex which was producing the problem or whether it was the ACTH which was producing the problem. So you should remember that Cushing's syndrome or Cushing's disease can be caused because of increased ACTH production, or it could be because of an increased production of the cortisol from the adrenal cortex. So both the things can be the cause of Cushing syndrome. Previously, it was separate, like Cushing syndrome and Cushing's disease were separate. Now both are being told as Cushing syndrome only. Then second question is, explain the physiological basis of her hypertension in the context of Cushing syndrome. I told you the patient is hypertensive. So we should be able to explain the hypertension. Why does she have hyperglycemia? How does the high-dose dexamethasone suppression test help distinguish between pituitary and ectopic ACTH production? See, remember, normally ACTH is produced by the pituitary, but in certain cancers, ACTH is also produced. So, any ACTH production other than from the pituitary, it is called ectopic ACTH production. So, this test is very important in differentiating the pituitary ACTH production and the ectopic ACTH production, how I will be explaining later on. What changes would you expect in her muscle histology and why? I told you she is having proximal muscle weakness. So, what changes would we expect in her? So, most likely diagnosis cause is Cushing's disease. I told you previously it was separate, Cushing's disease and Cushing's syndrome, but now it is the same. Cushing's disease is ACTH secreting pituitary adenoma. So there is a tumor in the pituitary which is producing more and more ACTH. So elevated ACTH will cause the adrenal cortex to produce more amount of cortisol. Partial suppression with high dose dexamethasone, which is typical of pituitary edema. That means if it is a pituitary secreting the ACTH, then there is a suppression with high dose dexamethasone. But if it is not the pituitary which is producing the ACTH, it is coming from some ectopic ACTH tumors, they will not be suppressed. So this partial suppression with high dose dexamethasone is a very easy test to perform to make out and differentiate between a pituitary adenoma which is causing the increased ACTH as well as an ectopic ACTH tumor. In addition to that, I also had put in the case that an MRA evidence of pituitary lesion is present. So all this will will put the diagnosis as Cushing's disease. So what is Cushing's disease? It is the increase in the cortisol production because of an increase in the ACTH, which is produced from the pituitary by a pituitary adenoma. So this is the explanation for the cause of the disease. Then second thing is, what is the cause of the hypertension? Cortisol excess increases sensitivity of the blood vessels to catecholamines by upregulating the alpha adrenergic receptors. See, yesterday when we were talking about thyroid, I told you this is also seen in one disease. What was that? This upregulation of the alpha 1 adrenergic receptors. Was it hyperthyroidism or hypothyroidism? Very good. In hyperthyroidism, I told you in Graves' disease also, there is an upregulation of the alpha 1 adrenergic receptors. That's why there also you have increased heart rate and all that. At high concentrations, cortisol can bind mineralocorticoid receptors, leading to sodium and water retention. So here, though it is a glucocorticoid, it has a mineralocorticoid action. Just like aldosterone, it helps in the absorption of sodium and along with the sodium, water. So this will cause an increase in the blood volume, which increases the blood pressure. So combination of increased peripheral vascular resistance plus expanded intravascular volume causes an increase in the blood pressure. Whereas in hyperthyroidism, I told you what happens. There is a decrease in the diastolic blood pressure, but there was an increase in the systolic blood pressure. Why was that? Because of the increased production of heat in hyperthyroidism, there was vasodilatation. Because there was vasodilatation, there was a decrease in the diastolic blood pressure. But because there was an increase in the heart rate, there was an increase in the systolic blood pressure. So in hyperthyroidism, it is like that. But here, both the systolic and diastolic blood pressure is increased. Why? Because of the sodium and water retention, there is an increase in the blood volume, which causes an increase in the blood pressure, as well as because of the alpha 1 adrenergic receptor activity, there is an increase in the peripheral vascular resistance. So both these, that is increase in the peripheral vascular resistance and the expanded intravascular volume, cause an increase in the blood pressure. So this causes the hypertension. Then reason for hyperglycemia. Yesterday also I told you in Graves' disease there was hyperglycemia. So here cortisol stimulates hepatic gluconeogenesis and inhibits glucose uptake in peripheral tissues. That means it causes insulin resistance. So insulin resistance and gluconeogenesis. What do you mean by gluconeogenesis? Glucose is formed from other sources, for example, proteins. So this causes protein catabolism, promotes protein catabolism, and the amino acids are used for gluconeogenesis. Whereas in thyroid, when I told you, in normal doses, thyroxine is anabolic, but in high doses, it is catabolic. So that is why there was gluconeogenesis, which caused uh, increase in the blood glucose in hyperthyroidism. Here also, gluconeogenesis is seen because the proteins are catabolized, which causes an increase in the glucose, hepatic gluconeogenesis. Net effect is persistent hyperglycemia, which may progress to secondary diabetes mellitus. So, if the sugar increase in the glucose is not because of the decrease in the insulin, then it is called secondary diabetes mellitus. Secondary diabetes mellitus means some other cause is present which causes an increase in the glucose. Then the role of the high dose dexamethasone suppression test, I told you this is used to differentiate whether it is a pituitary adenoma which is causing the ACTH increase or an ectopic ACTH producing tumors. An example for you is small cell lung carcinoma. I added this because there are some students who are also from third year. That's why I added certain uh, diseases names. So pituitary adenoma is easily suppressed by the increase in the cortisol level. So when the high dose dexamethasone suppression test is done, cortisol levels partially suppress. Whereas in ectopic, there is no suppression even if you are having a high dose dexamethasone. So in this patient, partial suppression favors that it could be the pituitary source. So one is this dexamethasone suppression test favors that it is a pituitary source. Second one is MRI showed a pituitary adenoma. That's why it could be because of Cushing's disease. Then what are the expected muscle histology changes? Type 2 muscle fibers atrophy. This is very, very important. Type 2 muscle fibers atrophy in the proximal limb muscles. That's why they find it very difficult to walk properly. The strength of the muscles will reduce. It is caused by the protein catabolism from excess cortisol. So it causes muscle wasting. So you will see that the legs are very, very thin and the body is very, very huge. The person will be having an obese body, a protuberant abdomen, a round face, a buffalo hump, but the legs will be like toothpicks. Suppose you put a ball and you put toothpicks, the person will be looking like that. The whole body is obese, but his legs are very, very thin. So I'll be sending this PDF to you. You can make out what is the difference between the Cushing syndrome and so I hope you understood about Cushing's disease. This is second commonest after thyroid. Cushing syndrome is also a very commonly given question. So you be thorough with the actions of cortisol and Cushing syndrome. Now we come to the second clinical case. Here it is a 25-year-old man presents to the clinic complaining of excessive thirst and urination for the past 3 weeks. Excessive thirst is called polydipsia and excessive urination is called polyuria. See, remember, polyuria means increased urination. Oliguria means decreased urination, but it is not oligosaccharides in the urine. I hear some of the students telling oliguria means oligosaccharides in the urine. Understood? Polyuria means polysaccharides in the urine. Don't make such silly statements. Understood? Excessive thirst is polydipsia. Excessive urination is polyuria. He reports drinking nearly 8 to 10 liters of water per day and waking up multiple times at nights to urinate. He denies dysuria. Dysuria means burning sensation when you are passing urine. So suppose there is a urinary infection, even then there will be polyuria, but the urine will be having some burning sensation. So that is called dysuria. He denies dysuria, hematuria. Hematuria means blood in the urine or changes in the appetite. That means if it is some other disease, there will be polyphagia also. But here he is not having polyphagia. He is not having any change in the appetite. So only problem with him is he is having excessive thirst and excessive urination and the duration is 3 weeks. Past history is unremarkable. no recent trauma, head injury or surgery. This is also very important in the history. He should, if he is having a head injury or a trauma, then it is called syndrome of inappropriate ADH production. So that is one disease. So there, it is not necessary for physiology, but people who are there from the other years, you remember that head injury is a very important history you have to take if he is having these problems. Medications used is none. Family history is non-specific. On examination, BP is 105 by 70 millimeters of mercury. That means he is hypotensive. BP is low. He is hypotensive. Heart rate is 92 beats per minute. So, though it is within the normal range, there is an increase in the heart rate. Temperature is normal. Mucous membranes are dry. No peripheral edema. Mucous membranes are dry means he is dehydrated. No peripheral edema. Serum sodium is 150 milliequivalents per liter. That means serum sodium has increased. See, you should all be knowing the normal values of sodium, bicarbonate, potassium. Remember that. Okay. Serum sodium 150 milliequivalents per liter. Serum osmolarity 305 milliosmoles per kg. So it is increased. Osmolarity has increased, sodium has increased. Urine osmolarity is very low, 80 milliosmoles per kg. So serum osmolarity is high, urine osmolarity is low. Then water deprivation test. Urine osmolarity remains low after dehydration. That means if you don't give the patient water for though he is feeling thirsty, then urine osmolarity should increase. But here, even if you deprive the patient from water, urine osmolarity remains low. Though he is dehydrated, urine osmolarity remains low. This is one important test. Increases significantly after administration of desmopressin. So, desmopressin is a synthetic ADH, or ADH is also called as vasopressin, isn't it? So, desmopressin is a synthetic ADH. If you administer that, then the urine osmolarity is increasing. So, what could this be? Very easy. What could this be? Yeah, Yuraj, what could this be? Very good. So, this is diabetes insipidus. So, based on the clinical and laboratory findings, what is the most likely diagnosis? What physiological defect underlies this condition? I'll be telling you about the two types of diabetes insipidus. How does the water deprivation test help distinguish between central and nephrogenic diabetes insipidus? So you have to remember diabetes insipidus is of two types. One is called the central diabetes insipidus. Second one is called the nephrogenic diabetes insipidus. Central diabetes insipidus means there is a decrease in the ADH production by the pituitary. Understood? Nephrogenic diabetes insipidus means the ADH production is normal, but its action is not normal. Its action is reduced. That means it is not able to bind to the receptors. So you have a central diabetes insipidus and a nephrogenic diabetes insipidus. Fourth question. Which part of the nephron is primarily affected by the lack of ADH activity? This is a very, very important question. This is asked in the Viva also. Understood? Which part of the nephron is primarily affected by the lack of ADH activity? Why is the patient hypernatremic despite drinking large volumes of water? This is another important question. Why is the patient hypernatremic despite drinking large volumes of water? Because when you are drinking a large volume of water, along with the water, the sodium also should go off, isn't it? So the amount of sodium in the blood should decrease. But here, the patient is hypernatremic. So these are the reasoning questions you have to answer. So central diabetes insipidus. Why am I able to tell that it is central diabetes insipidus and not nephrogenic diabetes insipidus? One thing is, it is diabetes insipidus because the patient is having polyuria, polydipsia, hypernatremia, high plasma osmolarity, and dilute urine. All this makes out that he is a diabetes insipidus patient. Polyuria, polydipsia, hypernatremia, high plasma osmolarity, and dilute urine. So I jokingly tell, if you ask the patient to bring 1 day of urine and he brings it in 5 liter bottles, then it is diabetes insipidus. But suppose he brings only in 1 2 liter bottle or 2 2 liter bottles, then it is diabetes mellitus. Understood? Diabetes insipidus, he will be producing so much of urine. In the water deprivation test, I told you what is water deprivation test. That means you are not giving him water to drink, though he is feeling thirsty. Urine osmolarity increased after desmopressin. So, after giving ADH, the synthetic ADH, which is called desmopressin, the urine osmolarity increased, meaning the kidneys can respond to ADH. If suppose it was nephrogenic diabetes insipidus, then even if you have given desmopressin, the person will not be able to respond to ADH. So, the problem is lack of ADH production or release, not renal resistance. So, you can make out that it is a central diabetes insipidus because in the water deprivation test, urine osmolarity increased after desmopressin. So, the kidney is able to respond to ADH. So, what is the physiological defect? In central diabetes insipidus, there is insufficient secretion of ADH. Other name for ADH is vasopressin from the posterior pituitary. Often, it is due to hypothalamic or pituitary damage or idiopathic. So, hypothalamus might be damaged, pituitary, posterior pituitary may be damaged. This can cause a insufficient secretion of ADH. What does the ADH do? ADH normally increases aquaporin 2 channels in the collecting duct. So, where does the ADH function? In the collecting duct. What does it do? It helps in the production of aquaporin 2 channels, which helps in the reabsorption of water, allowing water reabsorption. Without it, the kidneys cannot concentrate urine. So, if the ADH is absent, the aquaporins are not produced near the collecting duct. So, whatever urine is coming is allowed to go out. So, that's why the patient will be having polyuria. Water deprivation test I told you. And what is the distinction? Urine osmolarity increases as ADH is released in response to dehydration if it is normal. That means if the patient is having a normal amount of ADH, he is absolutely normal. Then what will happen? When the person is dehydrated, the urine osmolarity will be increased because the body tries to conserve the urine. But in central diabetes insipidus, urine osmolarity stays low after dehydration but rises sharply after desmopressin. I told you. This will not happen in nephrogenic diabetes insipidus because there the kidneys are not able to respond to the ADH. ADH production is maybe normal. Nephrogenic diabetes insipidus. Urine osmolarity stays low both after dehydration and after desmopressin because the kidneys cannot respond to ADH. So I hope you understood what is the difference between central diabetes insipidus and nephrogenic diabetes insipidus. Central diabetes insipidus means the amount of ADH production itself is low. In nephrogenic diabetes insipidus, the production of ADH may be normal, but it is not able to act at the level of the kidney. It is not, the kidneys are not responding to the ADH because of resistance. Then the nephron site which is affected is the late distal tubule and collecting duct, specifically the principal cells. This is a MCQ question. See, for you, 5 questions are case dependent and it is a MCQ question also. So you have to remember, this is a common MCQ question which is asked. Late distal tubule and collecting duct, specifically the principal cells. These segments are ADH sensitive and adjust water permeability via the aquaporin 2 channels. So the channels are aquaporin 2. Yeah. Next question was, what is the cause of hypernatremia despite high water intake? Even with large water intake, excessive free water loss in urine exceeds the intake. The inability to concentrate urine leads to net water deficit, which increases plasma sodium concentration and osmolarity. What does it mean? Because the water is not being reabsorbed. Why is it not being reabsorbed? Because the aquaporin 2 channels are not there. Why are the aquaporin 2 channels not there at the collecting duct and the distal tubule? Because the ADH is not producing them. Why is the ADH not producing them? Because there is a decrease in the ADH production, or the ADH is not able to function at the level of the kidneys. So, though he is taking large amount of water, the water is going up, not the sodium. So, there is a net water deficit. So, when there is a net water deficit, the amount of sodium inside will be high. So, that's why the plasma sodium concentration and osmolarity will be high. So, I hope you understood this is a case of diabetes insipidus. Whenever you have a case of diabetes insipidus, you have to differentiate with whether it is central diabetes insipidus or peripheral diabetes insipidus. What do you mean by central diabetes insipidus? That means the amount of ADH. ADH is also called as vasopressin. Amount of ADH production itself is less. Then what do you mean by nephrogenic diabetes insipidus? There, the production of ADH may be normal, but the ADH is not able to function at the level of the collecting ducts or the distal tubules because the receptors are not functioning properly. So that's why they are not sensitive to ADH. So the water permeability will be going off as the aquaporins are not there. So desmopressin, what is desmopressin? It's a synthetic ADH. If you give desmopressin and the patient is able to, and the production of urine is less, that means whether it is a central or a nephrogenic diabetes. If you are giving desmopressin and the amount of urine production is less, is it a central diabetes insipidus or a peripheral nephrogenic diabetes insipidus? Charita. Very good. It is a central diabetes insipidus because desmopressin, I told you, is a synthetic ADH. So once you are giving a synthetic ADH, it is able to function normally. It is able to function normally. So there is no problem with the receptors at the level of the kidneys. So we completed 2. We come to the third case. A 46-year-old man presents to the outpatient clinic complaining of increased shoe size. So this is a very important sign. Complaints of increased shoe size over the past 5 years and difficulty wearing his wedding ring. Nowadays, many people are not wearing, but increased shoe size is the common complaint they will be having. He also reports headaches and occasional tingling in his hands. Tingling is there, numbness is also there. He also reports headaches and occasional tinglings in his hands. His wife mentions that his facial features have become more coarse and his voice deeper. See, in yesterday's talk, where was the voice change? In which disease did you have a voice change in yesterday's talk? Yesterday, we also talked about hoarseness of the voice. What was the name of the disease? Where there was a hoarseness of voice. Very good. Myxedema or hypothyroidism. Myxedema or hypothyroidism. There was a change in the voice, but the voice change was because of the deposition of the mucopolysaccharides. I told you. So there was some deposition in the vocal cords. That's why there was a hoarseness of the voice. Here also, his wife mentions that his facial features have become more coarse and his voice deeper. On examination, he has prominent brow ridges, an enlarged jaw, which is called prognathism. Prognathism means there is an elongation of the jaw. The jaw is protruding forward. So that's why it is called prognathism. So he has an enlarged jaw and thickened lips. Prominent brow ridges, enlarged jaw, and thickened lips. So these are the facial changes which are very, very important and easily you can make out. Blood pressure is 155 by 95 millimeters of mercury. That means there is both a systolic as well as diastolic hypertension. Blood pressure is 155 by 95 millimeters of mercury. Visual field testing reveals bitemporal hemianopia. This is also important. See, when anopia means there is a loss of the field of vision. Complete anopia means the person is blind in one eye. Hemianopia means he is blind in half a field. So, if it is the temporal field in which he is blind, it is called temporal hemianopia. If both the eyes there is a hemianopia in the temporal field, that is called bitemporal hemianopia. I'll be talking it in detail when we go to the slide. But remember here, there is a visual field defect. Laboratory result, fasting blood glucose is 132 milligrams per 100 ml. See, here also there is an increase in the blood glucose. So, this is the third case where there is an increase in the blood glucose. Serum insulin-like growth factor, IGF-1, insulin-like growth factor, is elevated. So, fasting blood glucose is high, insulin-like growth factor is high. Oral glucose tolerance test, growth hormone levels remain elevated after the glucose load. So, remember, whenever there is a glucose load, the growth hormone should reduce. So, here growth hormone levels are remaining elevated even after there is a glucose load. MRI of the brain shows a 1.5 centimeter pituitary mass. So, here also there is a tumor in the pituitary. See, in one case previously also I told you there is a pituitary adenoma. What was that case? Where there was a pituitary adenoma which was causing the disease. Yeah, Anuradha. What was that disease? Very good. I told you in Cushing syndrome also, there is a pituitary adenoma which is causing the increase in the ACTH. But here also there is a MRI which shows the 1.5 centimeters pituitary mass. So what are the positive findings here? Increased shoe size, then difficulty wearing his wedding ring, headaches, occasional tingling in his hands, facial features have become coarse, voice has become deeper, he has a prominent brow ridges, prognathism. What is prognathism? Prolongation of the jaw, enlargement of the jaw, and thickened lips, hypertension. Visual field testing reveals bitemporal hemianopia, fasting blood glucose hyperglycemia, insulin-like growth factor is increased, oral glucose tolerance test, growth hormone is not reduced even after the glucose load. MRI of the brain shows a 1.5 centimeter pituitary mass. So, what could this be? Anyone? What could this be? Very good. So, it is a case of acromegaly. So, you have to understand the difference between gigantism and acromegaly. Acromegaly. So, acromegaly means the disease has started after the fusion of the end plates of the bones. If the disease would have started in childhood, that means before the fusion of the end plates, then there will be a prolonged elongation of the bones. Here, there is only a thickness of the bones. That means the bones cannot elongate because the end plates have fused. So that's why there is only a thickening of the bones. So here you can see thickening of the lips, you can see coarseness of the face, you can see the jaw is protruded, you can see the hand, it is a little coarse, the fingers are very thick, legs also will be like that, it will be very big in size and it will be coarse. So headaches, some people may be having diplopia, some people may be having bitemporal hemianopia, finally they become blind. Some people may be having a thickening of the skull. Supraorbital ridges are all thick. Prognathism causing gap bite. cardiomyopathy is there. All the organs are increased in size. Enlargement of visceral organs. Patient has increased blood glucose. Skeletal muscles are weak. Broadening of the hands due to gross increase in the soft tissue, increase in the ring and shoe size. So, which pituitary cell type is overactive in this condition? This is very, very important. You have to know what are the cell types in the pituitary and which cell type is responsible for which disease. Because once you go to third year, there the pathology is also important. So, it is called pathophysiology. I would like to call it physiopathology, not pathophysiology. Because first the person will be having a normal physiology, then it is going to become a disease. That's why I always call it physiopathology. You should be knowing all that. So, which pituitary cell type is overactive in this condition and what hormone does it secrete? Second question. Explain the mechanism behind the patient's visual field effect. This is also important because here special physics question as well as endocrine question can be clubbed together here. See, there is a marking of marks for each chapter. And the highest marks in paper 2 is for CNS. Understood? So, most of the questions will be coming from CNS, whether it is my MCQ 35 marks is for CNS. Rest will be little less. Second highest is endocrines. Highest is CNS, second highest is endocrines. Why does the patient have hyperglycemia? Describe the feedback mechanisms involving growth hormone and IGF-1 in normal physiology and how it is disrupted here. What is the most likely cause of this patient's condition and what is the primary treatment? So, we will go to each question separately. So, cell type is somatotrophs. That means the eosinophilic cells. The eosinophilic cells are present in the anterior pituitary and these are the cells which are affected in acromegaly as well as gigantism. So, what is the hormone? Growth hormone. There is an excess of growth hormone. See, whenever the growth hormone is less, it causes a pituitary dwarf. See, previously, yesterday when we were talking about creatine, that was not a pituitary dwarf. That was a dwarf because of decrease in the thyroid hormone. We called it creatine. So, there we told that there is mental retardation because thyroxine is responsible for the formation of synapses, for the formation of the myelin. So many things are there. So, it is responsible for the development of the brain. So, that's why they are mentally retarded. So, they are dwarfs, but they are mentally retarded. Here, it is not like that. They are dwarfs, that means they are very short, but they will not be mentally retarded if the growth hormone is less. So, you have to remember that's the main difference between a pituitary dwarf and a thyroid dwarf. Understood? So, in a cretin, he will be mentally retarded. Pot belly will be there. I told you umbilical hernia is there. There will be a tongue which is coming out, a puffy face. All that will be there in the dwarf who is because of decreased thyroid hormone. Here, if there is a decrease in the pituitary, the person will be normal. I think you might have seen in movies at least, jokers in the circus. They'll be absolutely normal. They'll be having normal children. Everyone will be normal, but they will only be short. So that is because of the decrease in the production of growth hormone. Here, it is acromegaly where there is an increase in the growth hormone. In acromegaly, somatotrophs hyperplasia or adenoma increases growth hormone secretion, leading to excessive IGF-1 production from the liver and other tissues. See, insulin-like growth factors are produced from the liver, mainly by the liver and some other tissues. So, whenever the growth hormone increases, it stimulates the liver to produce more amount of IGF. So, there is an increase in the production of IGF-1 also. So, what are the cells? Somatotrophs. This is important. Explain the mechanism behind the patient's visual field defect. What was the defect I told you? Bitemporal hemianopia. See, it is very important for you to understand where is the lesion which causes different types of thing. So, first you can see total right eye visual loss. Where is the lesion? It is at the optic nerve. When the whole optic nerve is cut off, there is a total loss of vision. That is called anopia. It is called anopia. So you have to remember, when you see the blue color, that is the temporal part of the retina. Then the red color is the nasal part of the retina. Here you are seeing a green color, that is the nasal part of the retina, and you have the yellow color, which is the temporal part of the retina. So the temporal part of the retina takes the nasal field. The temporal field is taken by the nasal part of the retina. This you have to understand. The temporal part of the retina, this is the temporal part of the retina, will take the nasal field, whereas the temporal field is taken by the nasal part of the retina. And you can see here, only the nasal fibers cross, the temporal fibers don't cross. They go on the same side. So when there is a lesion at number 2, only the nasal fibers are lost. Nasal fibers are bringing which field? The temporal field. That's why you have a bitemporal hemianopia. Why do you have a bitemporal hemianopia? Because the nasal fibers of the retina are bringing the light from the temporal part of the field of vision. So the temporal field is collected by the nasal part of the retina. So here the nasal fibers are being, there is a pressure on that from above. That's why they are having a bitemporal hemianopia. Okay. So the pituitary adenoma grows upwards into the suprasellar region, compressing the optic chiasma. That part is called the optic chiasma, where the nasal retinal fibers cross. Nasal fibers carry temporal visual field information, so damage results in loss of peripheral vision on both the sides. Rest of the things we'll be talking when we come to special senses. Why does the patient have hyperglycemia? See how many people are having hyperglycemia other than diabetes mellitus. So hyperthyroidism had hyperglycemia. Then increased cortisol had hyperglycemia. Increased growth hormone has hyperglycemia. Then you have catecholamines where they increase also causes hyperglycemia. Only when there is a decrease in insulin which causes hyperglycemia. Glucagon increase will cause hyperglycemia. So there are so many hormones which cause diabetes. These are called diabetogenic hormones. The hormones which cause an increase in the blood glucose are called diabetogenic hormones. So growth hormone effect on metabolism. Growth hormone is a counter-regulatory hormone. It increases gluconeogenesis, decreases glucose uptake in muscle and adipose tissue, and increases lipolysis. So what are all the things that are happening? Gluconeogenesis is increased. Glucose uptake into the muscles and adipose tissue is reduced. And lipolysis is increased. So all this will cause an increase in the blood glucose. Chronic growth hormone excess causes insulin resistance. In addition to that, there is an insulin resistance, leading to persistent fasting hyperglycemia and sometimes to over diabetes mellitus. See, I think you know the fighter called Kali. So that fellow has diabetes mellitus. Understood? Because of so much of gluconeogenesis, decreased glucose uptake, the amount of insulin produced in the beta cells will go on increasing. Finally, the beta cells will get exhausted. They will not be able to produce insulin. Say they get destroyed. So finally, these people land up with diabetes mellitus, where there is a decrease in the insulin also. So though it is a secondary hyperglycemia in the beginning, it finally ends up with primary diabetes mellitus. Okay. So that is the cause. Then describe the feedback mechanism involving growth hormone and insulin-like growth factor 1 in normal physiology and how it is disrupted here. So normally, what happens? Hypothalamus releases growth hormone releasing hormone. This stimulates the growth hormone secretion from which cells? Somatotrophs. Growth hormone will stimulate the liver to produce insulin-like growth factor 1. Insulin-like growth factor 1 exerts negative feedback on both hypothalamus and the pituitary. So when it has a negative feedback, what will happen? Growth hormone releasing hormone also decreases the growth hormone also decreases. Somatostatin from hypothalamus also inhibits growth hormone release. This is in a normal person. So whenever the body requires growth hormone, it is stimulated by the hypothalamus to produce growth hormone releasing hormone. This will stimulate the liver to produce insulin growth factor 1. This will exert a negative feedback both on the hypothalamus and the pituitary. But in acromegaly, what is happening? There is a tumor in the pituitary, so which is commonly a pituitary adenoma, which secretes growth hormone more and more, bypassing the normal feedback inhibition. Even with high IGF-1 and somatostatin, growth hormone secretion persists. So there is no more negative feedback because of the adenoma, because of the tumor which is present in the somatotrophs, which is producing this growth hormone. There is no more negative feedback. Though there is an increase in the IGF-1 and somatostatin, growth hormone continuously is being secreted because the pathology is in the somatotrophs. Hope you understood. That's why the negative feedback doesn't take place. What is the most likely cause of this patient's condition? What is the primary treatment? So, pituitary adenoma is most common cause of acromegaly in adults. See, pituitary adenoma comes in middle ages. So, when it comes in middle ages, these are fused. The end plates have fused. So, that's why these people land up with acromegaly. So, mostly it is surgical resection. You don't have to know the names, but I put that because of some people who are seniors. Transsphenoidal surgical resection of the pituitary adenoma. From the sphenoid bone, they will be entering and removing the tumor. Then alternatives, somatostatin analogs. So these words are not for the physiology students. Octreotide and pegosamide are for the seniors who are joining. Okay. For the physiology exam goers, you remember transsphenoidal surgical resection. Surgical resection of the pituitary adenoma is the treatment. This much you remember. That's enough. Okay. So now we come to the last case. A 48-year-old man presents to the clinic with complaints of frequent urination. Frequent urination means polyuria. Excessive thirst means polydipsia. And fatigue for the past 3 months. Fatigue means feeling of weakness. He reports an unintentional weight loss of 5 kg despite an increased appetite. Where else did you get it yesterday? Unintentional weight loss. In spite of having a good appetite, the person was losing weight. Where did that happen? In yesterday also this came. There was a weight loss, though he was having an increased appetite. Anyone? Very good. So that was hyperthyroidism. Excellent. Hyperthyroidism, there was an unintentional weight loss in spite of having a good appetite. The appetite increased, weight loss. I told you what was the cause of weight loss there. Here also, there is an increased appetite and an intentional weight loss. So, increased appetite means polyphagia. He keeps on eating, but he's losing weight. He has a family history of diabetes mellitus in his father. So, he has a family history of diabetes mellitus. On examination, his BMI is 29 kg per meter square. Okay, so the BMI is body mass index. BMI means body mass index is a little high. Blood pressure is 140 by 88 millimeters of mercury. So it's also a little high. Pulse is 88 beats per minute. Though it is within normal, it's a little increased. Laboratory investigations show fasting blood glucose, plasma glucose is 178 milligrams per 100 ml. So fasting blood glucose has increased. HbA1c, glycosylated hemoglobin is 8.5%. So that is also increased. HbA1c has increased, fasting blood glucose has increased, BMI is increased, blood pressure has increased, then unintentional weight loss is there, his appetite has increased, his frequency of urination has increased, excessive thirst. So all these are there. But serum C peptide is normal. What is serum C peptide? Serum C peptide is the measurement of insulin. Understood? Whether the insulin is produced normally or not, you can make out by serum C peptide. So insulin is not normal. There is no deficiency of insulin at all. Serum C peptide is normal. Urine analysis is positive for glucose, negative for ketones. So there are no ketone bodies in the urine, but there is glucose in the urine. So what is this? The patient is diagnosed with type 2 diabetes mellitus and started on lifestyle modification plus metformin. So patient is diagnosed with type 2 diabetes mellitus. Why is it not type 1 diabetes mellitus? Because he does not have ketone bodies. Understood? In type 1, there is no insulin at all. The production of insulin is very, very low. So that's why ketone bodies are formed. So the urine will be having ketone bodies. Here, there are no ketone bodies, and that is why this is type 2 diabetes mellitus. So the questions are, explain the role of insulin resistance in the development of type 2 diabetes mellitus in this patient. Why is there an insulin resistance? Number 2, why is glucose detected in the patient's urine? And what is the concept of the renal threshold for glucose reabsorption? See, this is a 3 marks question for you. So, absorption of glucose is a 3 marks question. That will also be coming. Why is glucose detected in the patient's urine? What is the concept of renal threshold for glucose reabsorption? In uncontrolled diabetes, what is the main mechanism leading to weight loss despite increased appetite? That means he is having an increased appetite. Why is there a weight loss? That is the question. So you should be able to make out the difference between diabetes mellitus and hyperthyroidism. Why there is a weight loss there? Why there is a weight loss here in spite of an increased appetite? How does elevated blood glucose affect pancreatic beta cell insulin secretion? And why might this mechanism fail over time in type 2 diabetes? So what happens to the pancreatic beta cell insulin secretion? What is metformin's primary mechanism of action in lowering blood glucose, and how does it differ from insulin therapy? See, remember, type 2 diabetes is non-insulin dependent diabetes mellitus. That means insulin may or may not be needed for the treatment. But in type 1 diabetes, it is always insulin dependent diabetes mellitus. You remember, in type 1 diabetes, there is no question of oral hypoglycemics. Type 1 diabetes have to be take insulin. Type 1 diabetes is more common in children. So right from childhood, they should be taking insulin. Whereas type 2 diabetes may or may not require insulin. They may be controlled by simple diet or an exercise, or it may be controlled by some oral hypoglycemic agents. So in type 2 diabetes mellitus, insulin resistance means that the peripheral tissues, what are the peripheral tissues where insulin acts? Skeletal muscle, adipose tissue, and liver. These are the 3 main peripheral tissues where insulin has an action. Have a reduced ability to respond to insulin. That means the receptors in the skeletal muscle, adipose tissue, and liver are not allowing the insulin to function. That is called insulin resistance. It is not that the insulin production has reduced. Insulin production is normal, but the action of insulin has reduced. So that is called type 2 diabetes mellitus. In the skeletal muscle, what will happen? Decreased blood flow translocation, less glucose uptake. See, GLUT4 is glucose transporter. Okay. GLUT4, what happens? Whenever insulin is produced, whenever insulin is present, it helps in the translocation of GLUT4 to the cell membrane. So once these GLUT4 are attached to the cell membrane, they help in the transport of glucose into the cell. But once the GLUT4 is not present, the glucose cannot enter into the cell. They stay in the blood. That's why you have an increase in the blood glucose. So in the skeletal muscle, decreased blood flow translocation, so there is less glucose uptake. In the liver, failure of insulin to suppress gluconeogenesis. See, insulin, function of insulin is it suppresses gluconeogenesis. But here in the liver, the insulin is not able to suppress the gluconeogenesis. That's why there is an increase in the glucose production. So one is less glucose uptake. Why? Because the GLUT4s are not being translocated into the skeletal muscle membrane, tissue membrane. In the liver, failure of insulin to suppress gluconeogenesis. Then the pancreas initially compensates by producing more insulin. Because the present insulin is not functioning, it tries to produce more insulin. But over time, beta cells undergo functional exhaustion and relative insulin deficiency will develop. Same thing happens in growth hormone also. In growth hormone also, because of the insulin resistance, the pancreas, beta cells of the pancreas will start producing more and more insulin. When it is producing more and more insulin, same thing will happen. Functional exhaustion happens and relative insulin deficiency develop. I told you, no, in growth hormone, acromegaly, what happens? In the beginning, there is a secondary diabetes mellitus, but finally it will turn into a primary diabetes mellitus. That means the insulin itself is not produced there also. So in type 2 diabetes mellitus, insulin resistance means what are the peripheral tissues in which the insulin acts? Skeletal muscle, adipose tissue, and liver. They have a reduced ability to respond to insulin. See, one important function of insulin you have to remember is insulin is responsible for the transport of potassium into the cells. This is a very, very important function of insulin. Generally, we'll write metabolism, everything correctly, but many of you forget to write this important function of insulin. Why? Because suppose the patient is having a kidney failure and is having hyperkalemia. What do you mean by hyperkalemia? Hyperkalemia means there is an increase in the serum potassium. So this will cause so many problems. Hyperkalemia can cause cardiac arrest also. One of the causes of cardiac arrest is hyperkalemia. So when this happens, when there is an increase in the potassium, that potassium has to be sent into the cells. So what do? They give insulin. But if you give insulin along with the potassium, glucose also will be going into the cell, isn't it? The patient may become hypoglycemic. That's why they give insulin in 25% dextrose. That means dextrose is also given, insulin is also given. So this insulin helps in the transport of potassium into the cells. So remember, don't forget to write about that function of insulin. You will be able to write about function on lipids, function on proteins, function on carbohydrates, but you forget to write the function on ions. Renal physiology. Glucose appears in the urine when plasma glucose exceeds the renal threshold, 180 milligram per 100 ml, which is the point at which the sodium glucose transporters in the proximal tubules become saturated. So remember, glucose is transported by two mechanisms. One is called the GLUT. I told you, glucose transporters. So GLUT1, GLUT2, like that. And the GLUT which is responsible for, which requires insulin is called GLUT4. This is another transporter which is called the sodium glucose transporter. This is also present. Sodium glucose transporters means they transport glucose very, very fast. But they have a limit. That means once the transporters are totally used up, no more glucose can enter into the cell. Is it clear? It cannot transport if the transporters are fully occupied. So when these SGL2 transporters in the proximal tubule become saturated, they will not be able to reabsorb the sugar. I think you know, isn't it? Glucose is 100% absorbed in the proximal tubules. Whatever is filtered is reabsorbed in the proximal tubules. But here, because the SGL2 are become saturated, no more glucose can be absorbed. In this patient, fasting blood glucose is 178 milligram per close to the threshold, but post-meal levels exceed 200 milligrams, causing glycosuria. So in this patient, fasting blood glucose is also high, postprandial blood glucose is also high. So this is a case of diabetes mellitus. Why is there a weight loss despite increased appetite? I told you one more hormone where there was a loss of weight in spite of increased appetite was thyroxine. Here it is entirely different. In insulin deficiency or resistance, glucose uptake into the cells is impaired. I told you, GLUT4s are not brought to the cell membrane to reabsorb the glucose, leading to a perceived cellular starvation. That means there is so much of glucose, but the glucose cannot be taken into the cell. So it is wasted. So the cells are always hungry. Understood? Cells are always hungry. That is called cellular starvation. The body mobilizes fat stores, lipolysis, and protein, muscle breakdown to provide energy, leading to catabolism and weight loss. So the body mobilizes, uh, it requires energy, isn't it? So the body mobilizes the fat stores. There is an increase in the destruction of fat. So that is called lipolysis and muscle breakdown. So gluconeogenesis will happen, and that is going to produce the energy, leads to catabolism and weight loss. So the person loses weight. One is because of lipolysis, second one is because of breakdown of the protein. Person will be having increased appetite because of another reason, polyphagia. See, normally all cells require insulin for the transport of glucose, but there are certain cells which don't require insulin for the transport of the glucose. For example, brain, the nervous tissue don't require insulin. In the same way, retina does not require insulin for the transport. Intestines, they don't require insulin. The kidneys don't require insulin for the transport of glucose. There is a few, or RBC. RBC also don't require insulin for the transport of glucose. They can be taken directly. But in the brain, though I have told brain does not require insulin for the transport of glucose, there is a particular nucleus in the hypothalamus which requires insulin for the transport of glucose. That is called the satiety center. Satiety center, which will tell the person, okay, you can stop eating. Now I am happy. But the satiety center requires insulin for the transport. When the insulin is deficient, the satiety center will always be unsatisfied. The person goes on eating. So that is one more reason for polyphagia. Hormonal regulation. In a healthy physiology, elevated blood glucose stimulates beta cells to secrete insulin. GLUT2 mediated glucose entry. This was normal in the liver and other places. Increased ATP ADP ratio, closure of ATP cells to potassium channels, depolarization of calcium influx, insulin will come out. So, insulin exocytosis. Whereas in type 2 diabetes, chronic hyperglycemia causes glucotoxicity. So, in diabetes mellitus, what happens? Chronic hyperglycemia causes glucotoxicity and elevated free fatty acid, which causes lipotoxicity. So, both the things happen. Glucotoxicity because of hyperglycemia, lipotoxicity because of the increased free fatty acids. Both these will damage the beta cells. So, after some time, the insulin cannot be secreted normally. So, this is the final thing which happens. Metformin, primary mechanism. This is for the seniors, but they have asked you also for physiology. What it happens is it decreases hepatic gluconeogenesis. This is the most important action of metformin. Decreases hepatic gluconeogenesis. Second one is increases insulin sensitivity. These two are very, very important functions of metformin. Decreases the hepatic gluconeogenesis, which is the main action, and increases insulin sensitivity in the muscles. So remember, metformin cannot cause hypoglycemia, but metformin is given with other sulfonylureas, so that causes the hypoglycemia. So people using metformin only will never become hypoglycemic because it only prevents hepatic gluconeogenesis and increases the insulin sensitivity to the muscle. So that's why the glucose uptake from the peripheral tissues is increased. It does not increase insulin secretion, unlike sulfonylureas. So it does not cause hypoglycemia in monotherapy. 1 gram is also given, hmm, metformin, but metformin has other side effects. Uh, but for you, all that is not necessary. Difference from insulin therapy directly increases circulating insulin levels. When you are giving insulin, it directly increases the insulin levels, promoting glucose uptake and storage, whereas metformin acts indirectly by improving the body's use of existing insulin and reducing glucose production. So remember, if insulin is given, it also causes a little weight gain, because one of the functions of insulin is lipogenic. It is lipogenic. It is anabolic. It is lipogenic. So the patient who is receiving insulin also becomes obese. But that is not needed for you. So metformin, what is the main action? Reduces hepatic gluconeogenesis. What is the other action? Increases insulin sensitivity in the muscle. So today you have learnt about diabetes insipidus, diabetes mellitus, then about the cortisol excess, and also about growth hormone increase after the bones have stopped growing. So next will be cardiovascular system tomorrow. So if you have any doubts, you can ask me. Thank you very much for listening patiently. So this is one of my favorite leaders of our country. To succeed in your mission, you must have single-minded devotion to your goal. So he was from a very, very humble background and he rose to become the President of India. So nothing is impossible in India. Only thing is, you have to be focused on your goal. Thank you.
Thank you, sir.
Okay.
On behalf of JSL Medical College, Rajahmundry and National Medicos Organization, heartfelt thanks to all for joining day 2 of Physiology clinical cases discussion. Special thanks to Dr. Pernenki Srinivasa, sir, Professor, Department of Physiology, JSL Medical College, for his insightful session on Endocrinology Part 2. And to Dr. Sagar, sir, Organizing Secretary, National Medicos Organization, for his support. Looking forward to seeing you in our upcoming sessions. I will end up this session with Shanti Mantra. Thank you.
Sahana bhavatu, sahanau bhunaktu, sahaviryam karavavahai, tejasvinavaditamastu ma vidvishavahai. Om Shanti Shanti Shanti.
Thank you, sir.
Thank you. Thank you so much.
I also thank Team Clirnet, Ritu Coordinator, and Rimpa, the moderator of this session. Rimpa, are you there?
Yes, sir. Yes, I'm there.
Yes.
So thank you so much, everyone, for joining this session. Clirnet is really glad to have all these brilliant people together. So with all your permission, shall I close the session for today?
Yes, Rimpa. Thank you for this
Okay.
session.
Thank you,
Thank
sir,
you.
and happy Independence Day to everyone.
Oh, thank you. Same to you.
Thank you, sir.
Rimpa, you can end up the session.
Yes, sir.
Yes, thank you, Rimpa.
Sir, thank you, sir.
Thank you.